This is Urban Health Today, and I'm speaking with Dr. Andrew Hertler, a nationally recognized leader in the management of oncology practices and CMO of Evolent. He's here to talk about the importance of prophylactic mastectomy for individuals carrying the BRCA1, BRCA2, and other gene mutations. It's great to have you back, Dr. Hertler.
Thank you. It's a pleasure to be here.
Thank you. All right, let's get started. Can you explain what BRCA1 and BRCA2 genes are and their significance in breast cancer risk? And what are some other gene mutations responsible for increased breast cancer risk?
Okay. Well, BRCA1 and BRCA2 are what we call DNA repair genes. Our gene pool, the DNA within our cells throughout our lives, is constantly exposed to numerous environmental factors. And these factors do cause mutations to occur. And why do we not all develop cancer all the time? And the answer is because we have a number of different genes that form proteins, that literally enzymes that circulate through our body, find these mutations and repair them. There are numerous repair genes, but BRCA1 and BRCA2 are some of these repair genes, and if mutated and you lose some of your ability to repair ongoing mutations, and that increases your risk of developing cancer. So that's the first part of your question. The second was, are there other mutations which can cause breast cancer? And there are. Certainly the most important are the BRCA1 and BRCA2. They cause the large majority of hereditary breast cancer. And hereditary breast cancer, by the way, makes up just under 20% of overall breast cancer. The remaining be what we call sporadic, not associated with hereditary gene mutations. But some of those other syndromes, there's something called Li-Fraumeni syndrome. There's Cowden syndrome, and that's a mutation in a gene called PTEN, P-T-E-N. There's Lynch syndrome would be another. There's homologous recombination deficiency. So those are several of the other mutations which can cause breast cancer that people are not as familiar with because the ones they think of most commonly are the BRCA1 and BRCA2.
You know, I had a friend, who had she had the ATM gene.
Yep.
Mutation.
That's
And
another one, ATM. That would
that
be
one was pretty tricky because the mammography accelerated her cancer. So that was a tough case. But she's fine. She survived it. She's cancer-free.
Well, that's good. That's very good.
How do you assess breast cancer risk in individuals carrying genetic mutations like BRCA1 and BRCA2?
That's a complicated question. Overall, patients who have a BRCA1 or BRCA2 mutation have a risk of breast cancer of somewhere between, generally we cite 45% to 85%. And that's a wide range. And the reason for that wide range is because these are genes which have many genes are made up of what are called nucleotides. And there are many nucleotides within a gene, numerous. And each of those can be mutated, which is when one mutation is substituted for another mutation. So just a second. And of these mutations, they can have differing likelihoods of causing breast cancer. So what I'm driving at is it depends upon the individual mutation. And when the testing is done, as a physician, we'll get a report of that will give us an idea of what the degree of risk is for this individual mutation. There are some mutations which are what we call mutations of undetermined significance. In other words, some mutations are silent. They may be there, but they don't affect the function of the gene, and there's no increased risk factor. There's some mutations we know are not deleterious. There's those that we know are, and there are those that we're unsure of. But if you have a deleterious mutation, we know that you're in that at least above 45%, and that's really an unacceptable high risk for developing breast cancer. When you realize that for someone who doesn't carry a mutation, they're going to run around a 6% risk of developing breast cancer in their lifetime. So 45%, even 45%, which is the lower end of that range, is unacceptably high. And not to forget, they also have a risk of developing ovarian cancer,
Right.
and that risk varies from 10% to 46%. In some ways, that's even more difficult because we don't have effective screening for ovarian cancer.
What exactly is prophylactic mastectomy? What can that procedure entail?
It's actually a fairly simple procedure. And why do I say simple? Because you're never opening a body cavity. In a way, it's an amputation. It's an amputation of the breast. And in a prophylactic mastectomy, generally what's called a simple mastectomy is done. They are not trying to take all of the tissue underneath the breast. They're going to remove 95% of the breast tissue with it. Very often, they will try to leave the skin and nipple behind, especially if there's going to be an attempt at reconstruction, but not always. It's now a procedure that can be done as outpatient surgery with patients never even being admitted to the hospital. And generally speaking, prophylactic mastectomies for someone who carries a BRCA or mutation or one of these other mutations will be bilateral. They'll do both breasts at the same time.
So what kinds of data did the National Comprehensive Cancer Network and the ACS rely on to recommend that high-risk carriers of genetic mutations undergo preventive breast surgery?
Well, I guess first of all, they recommend that it be considered. I don't think anyone would recommend that it make it a hard and fast recommendation. I spoke to a woman yesterday about prophylactic mastectomy, and in someone who has a BRCA mutation, it is certainly something to strongly consider, and it is very, very reasonable to have a prophylactic mastectomies. Because when you have it, you dramatically decrease your risk of breast cancer. You do not take that risk to zero. I already mentioned that a little bit of breast tissue is always left behind, no matter how aggressive you are with the surgery. But it decreases the risk, and we know this historically, by about 95%. So that's a dramatic reduction in the risk of developing breast cancer. And it's certainly something that women with a deleterious BRCA mutation should strongly consider. And I think that's how most of us put it. We think the most, in terms of preventing breast cancer, it's the most effective step you can take. That being said, some women just do not want to undergo prophylactic mastectomies, and the alternative is a very aggressive screening program. And by very aggressive, it's not mammograms every year. It's generally a mammogram and an MRI every 6 months. So that is the alternative route to go. It obviously is not going to be quite as effective as simply performing a prophylactic mastectomy. When you do the mastectomy, you're eliminating much of the breast tissue. If there isn't all that breast tissue, there's less likelihood of getting breast. The screening is not going to decrease your risk of getting breast cancer. It just allows you to detect it early enough that you can intervene and the patient will still have an unchanged chance of overall survival. So prophylactic mastectomy is the most effective step to take in terms of preventing or decreasing the risk of breast cancer, which is why it is recommended that it be offered as an option that is very, very reasonable for a woman to choose.
So the only reason that it's not recommended is because it's unpopular?
It gets to the essence of what we call shared decision making. This is not an inevitability. Yes, you have a high risk of developing breast cancer, but there are patients who have BRCA mutations who never develop breast cancer.
That's correct.
And there are women who have just it's an individual decision. I would say my experience is the large majority of women elect prophylactic mastectomy. But it's somewhat similar to when a woman has a breast cancer, we can generally offer what we call a lumpectomy versus a mastectomy. And that's an individual decision. The majority of women choose a lumpectomy. Some choose a mastectomy. Some choose mastectomy and reconstruction. So ultimately, my job, I feel the physician's job is not to talk someone into something or say they have to have it. My job as a physician is present the information to the patient and say, this is 95% of a prophylactic mastectomy would be 95% effective at preventing breast cancer. With screening, you still are going to run that risk. The strategy is different. We're hoping we detect it early enough that you would never die of a breast cancer. But if you do develop one, you will need surgery and treatment, etc. Lay out all the information as clearly as we can and let them make the decision that's best for them. Now, I'll tell you one question that not infrequently arises. The patient will turn to me and they'll say, "What would you do if I was your wife?" I get that question or got that question all the time. If asked that question, I would tell her to have prophylactic mastectomies, because that is what I would tell my wife. I would not tell her that she has to have it. I would say, you asked me what I would do, and I would do the prophylactic mastectomy. Why? I'm an oncologist. My number one goal is to keep people from having or dying of cancer. That's my first priority. I
Right.
understand that some women feel very, very cognizant. To them, their body image is incredibly important. I have seen undue pressure, sometimes brought by spouses who are probably more attached to their wives' breasts than they are. So there are, and do I think that's right? No. And do I try to educate that spouse? Absolutely. But there are a lot of reasons why a woman might make a different decision.
What are the benefits of prophylactic mastectomy for those with genetic mutations? And how do they impact overall prognosis?
Yeah, it's 95% effective at preventing breast cancer. So you can't say zero, but one is very unlikely to ever develop breast cancer after a prophylactic mastectomy.
What would you say is the percentage of women, let's say out of 100 women that do the mastectomy, I know it's 95%, but what percentage of those women end up having?
I'm just reflecting on my own experience. So
yes, on your own experience.
I would say it's 80 to 90%.
So about 10 to 20% do end up having some sort of cancer.
And then there are some women, and this is something else that I actually should have thought of and mentioned further. I've had some younger women who want to first have a child and breastfeed the child. So it's not always a case of completely declining prophylactic surgery, but saying, I want to defer this for 5 years, or put this off a few years and just aggressively screen me. So that's another reason that I've seen for not immediately proceeding to a prophylactic mastectomy. And generally, we'll do a prophylactic oophorectomy and take out the ovaries at the same time because of the risk of ovarian cancer. And they may want to have children. That's another common reason for not
Right.
immediately proceeding that route.
How do oncologists or surgeons approach the decision-making process with patients about the surgery?
And this is my approach, would be to present the option of prophylactic mastectomy with the option of screening. But I think my presentation strongly comes out that I will repeatedly say it's a very reasonable option, and that to proceed with a prophylactic mastectomy, that many women or the majority of women choose prophylactic mastectomy. So without saying you have to have a prophylactic mastectomy, I'll make it very clear that the evidence suggests this is the best route to go to prevent breast cancer. Now, I suspect there may be some people out there, some physicians out there who take a more aggressive approach and say you have to have a prophylactic mastectomy. That was never my approach. I don't think that's the majority approach. If you read the NCCN guidelines, it says it should be offered, should be strongly considered, the same kind of words I'm using.
Mm-hmm.
I hope that no one would suggest that you do screening and not consider a prophylactic mastectomy. To me, that would be inappropriate. And I would hope that no one would say that.
What are the potential risks or complications associated with prophylactic mastectomy?
From a physical standpoint, it would be infection. It's rare. If you have immediate reconstruction or an implant done, the infection risk gets a little higher. But that would be the number one risk. And that may say, oh, what's a little infection? It could be a severe infection. It could, you could have what's called sepsis. Even rare, very rare, but that is always the risk of any surgical procedure. And if you implant something in the body, that risk goes up a little bit. From a physical standpoint, it would be infection. It's rare. If you have immediate reconstruction or an implant done, the infection risk gets a little higher. But that would be the number one risk. And that may say, oh, what's a little infection? It could be a severe infection. It could, you could have what's called sepsis. Even rare, very rare, but that is always the risk of any surgical procedure. And if you implant something in the body, that risk goes up a little bit. I think there's probably a psychological risk. Does this change your
Quality
body
of
image?
life.
Are you going to be depressed? Quality of life, feelings about one's sexuality, it could all be a risk of proceeding with that route. Those are probably more common than the actual physical risk of infection, because it is a quite safe procedure to do.
And what are some alternatives to prophylactic mastectomy for genetic mutation carriers? How do they compare in terms of effectiveness?
I mean, the alternative is really the screening. And I wish I could, I mean, in terms of effectiveness, if your effectiveness is preventing one from getting breast cancer, markedly less effective, because if all you're doing is screening, you're looking for the breast cancer that arises. You're doing nothing to prevent that breast cancer from ever arising. We can put people on a drug, tamoxifen, and that does decrease the risk somewhat of developing breast cancer. That would be another alternative. So that actually plays some role in risk reduction, would be tamoxifen with aggressive screening, but that is going to have the side effect of primarily of hot flashes. And oddly enough, there's a very small increase in the risk of uterine cancer when you take tamoxifen. It's also going to do little to prevent the risk of ovarian cancer. So those would be the chief alternatives.
And in terms of effectiveness, comparable effectiveness, how do they? So obviously surveillance is not as effective as prophylactic
Yeah.
mastectomy.
Now, if you divide, and I don't know the statistic off the top of my head, but if effectiveness is what are your chances of being, if you have a BRCA mutation,
Right.
and you compare prophylactic mastectomy versus surveillance with or without tamoxifen, what are your chances 25 years later of being alive and never having, not whether or not you got breast cancer, but being alive? I don't know if there is any data. There may be, and that's what I was thinking, because we've known about BRCA for over 25 years now. And I can try to see if there is any data, but it's not something I can pull off the top of my head. My guess is that with aggressive screening, it's pretty close. That yes, your risk of getting breast cancer with screening versus prophylactic mastectomy substantially higher, but your chances of dying of breast cancer are probably only slightly higher, but if you do the aggressive screening program. But that's completely my estimation. I have not seen any data on that. You've got me interested in it. There might be now, because we've known about these mutations for a long time now, for over a quarter century.
And how long would you have to take tamoxifen for it to be comparable to prophylactic mastectomy?
It's generally taken for 5 years. And that's not comparable even then, but 5 years to get the benefit. And some women take it longer.
In your estimation, how does patient education on genetic risk and preventive options vary across different socioeconomic or cultural groups? And what can be done to bridge any gaps?
Yeah. I'm glad you said in your estimation. My concern is with regard to different socioeconomic groups that one, there's a huge education component about this. And there is difficulty access. If someone is diagnosed with these mutations, genetic counseling is recommended, but access to genetic counseling is difficult. I practiced for many years in Maine, and I was in the state capital, but the nearest genetic counselor was 75 miles away. We actually set up a telemedicine genetic counseling program for that reason. So access genetic counseling, I think, is a potential problem. I worry that in many urban areas and socioeconomically depressed areas, there is less access to genetic counseling. I think that if there are any language barriers, that could further prevent education on the genetic risk above and beyond the access problem genetic counseling. So if I see a patient who only speaks Spanish, then I'm not only looking for a genetic counselor, I'm looking for a genetic counselor who can speak Spanish, or a genetic counselor with a translator at the same time. So I think that's another potential gap. And then I think that at times there is a mistrust of the medical care system by people from backgrounds that have been historically discriminated against. And I think this can also potentially create a disparity in the the kind of healthcare, getting the kind of healthcare we want to every patient, regardless of their socioeconomic group. We have trouble even getting screening done on a regular basis. So when you talk about things such as genetic counseling, genetic testing, education regarding the genetic testing, that's a real concern. And when I was in practice, I saw a lot of rural patients. I already mentioned the difficulty in accessing genetic counseling, and we saw a lot of patients from all. There's a lot of rural poverty in the country, and I mean, I would approach those patients the same as any other patient. If I got the history that worried me, if they had breast cancer at a young age, if they had a mother and or a sister with breast cancer, if there was male breast cancer in the family, if I saw the risk factors for a potential genetic mutation, I would talk to them. I would recommend testing, and I would educate them myself. And regardless of whether their insurance was commercial, Medicare, Medicaid, or no insurance, would do my absolute best to get that testing done, covered, completed, and have those discussions with them. Genetic counseling was a bonus. If I could get them genetic counseling, that's great. But I also know the data myself, and feel that many times, because of the lack of access to genetic counseling, we as physicians have to provide that counseling, and that's what we try to do. So is it an obstacle? Yes. Is it recommended that everyone gets genetic counseling? Yes. Does everyone get it? Absolutely not. There's too many places in the country where it's not available, where the patients can't travel to get it, where there may not be a telemedicine counselor available. Do I think that's a huge detriment to their care? I don't, because I think most good physicians can perform many aspects of that counseling, at least for something like BRCA, which is fairly well known. And I mean, I can quote you BRCA data off the top of my head. Can I quote ATM data off the top of my head? I can't. What would I do? I would have to look it up and go back and research it again myself to be able to talk to a patient. I have never seen a patient with an ATM mutation. I've seen numerous patients with BRCA mutations. So what you see a lot at, you get good at, I guess is what I'm saying.
So without the genetic testing, then access to the prophylactic surgery sounds impossible, right? Among different populations. So how do these disparities affect outcomes?
Generally speaking, I mean, one, genetic testing is a blood draw. So the only thing that would create a lack of access would be, for some reason, failure of insurance to cover, or complete lack of insurance. And generally speaking, there are guidelines. There's actually an algorithm for determining whether you should or should not do genetic testing for patients for a BRCA mutation. You literally plug in the formula, and it spits out a percentage risk of carrying a BRCA mutation. I'm not remembering right what the cutoff is. I think if it's more than a 6% risk, most insurance will cover it. Even Medicaid will cover it. In most states, realize Medicaid is a state by state plan, but in many instances, Medicaid will cover it. If you don't have any insurance at all, and there is a percentage, sadly, in this country who do not have any insurance at all. I could get into a whole diatribe about that being a failure of our society, but and you get fire protection, police protection, education, but you don't get basic health care. But don't get me going on that one. Then it's a problem, because if you don't have health insurance, very often you don't have much income. And the cost of this testing is in the thousands of dollars. I can't give you the exact cost now. You may know that, but it used to be in the $2,000 to $3,000 range to do this genetic testing, maybe more now. So that's usually beyond the ability of someone who doesn't have health insurance, or whose health insurance for some reason wouldn't cover it. And I didn't run into that too much. Most insurance would cover it. But then you're going to struggle to get it done. And so that would be the group that I think would have the biggest obstacle to the testing. If you're, for some reason, you couldn't get the testing at all, but your risk algorithm shows that a substantial risk that you have the mutation, you probably have a family history at all. And if one goes into the guidelines, if you have a marked family history, and I had a patient once, it was a woman who had breast cancer, and her mother had died of breast cancer, and her sister had breast cancer. And of course, I did genetic testing, and it was completely negative.
Really? That's
It was
interesting.
completely negative. And she, unfortunately, she developed metastatic breast cancer. She lived over 10 years. I got to know her very, very, very well. I watched her. She was a young woman in her late 30s. I watched her daughter
Wow.
grow up. And one of the saddest days of my life was when she passed away. I really loved that patient. And then lo and behold, about 5 years later, who comes in to see me with breast cancer?
Her
Her
daughter.
daughter.
Oh,
And her daughter was pregnant, to
oh,
make it even
wow.
more complicated.
Oh,
I
no.
sent her away. This is someone I sent her down to Boston. They did every genetic testing in the world and found nothing. And she came back, and I recommended a bilateral mastectomies based on the fact that I was now seeing this, and I had taken care of her mother. I actually took care of her sister. I hadn't taken care of her grandmother, but every woman in that family was getting breast cancer. There's obviously a mutation there we don't know
Yeah,
about.
that's what I was going to say, right? That this
And that
one that
was
you guys
my
haven't. Yeah.
logic. But in that kind of a family history, you can recommend, regardless of the genetic testing, which should be done, it's not unreasonable to recommend a mastectomy in my mind.
Can you talk a little bit more about the algorithm? Is that without genetic testing? How does the algorithm work?
There are a number of different models that are used, but generally speaking, the model that originally used, and which I used, was called the Gale model. That's fallen a little out of favor now because it's felt that it doesn't collect enough family history. There's another model now, which is frequently used. Well, there's two others. One is the National Cancer Institute Breast Cancer Risk Assessment Tool. The other is called the Tyler-Cuzick model. And the Tyler-Cuzick model looks at a number of different factors. It looks at age, it looks at breast density, it looks at weight, it looks at the age at your first menstrual period. We know that if you have a young first menstrual period, that actually increases your risk. It looks at whether you've ever had any children. And the more children that you've had, oddly enough, the lower your risk of breast cancer.
Right.
Because you have less exposure to estrogen over the course of your life. It looks at whether you've gone through menopause. It looks at whether you have used hormone replacement therapy. Obviously looks at whether or not anyone else in your family has tested positive for that disease. And then it looks at how many family members have had breast cancer or ovarian cancer, and then it generally asks if you're Ashkenazi Jewish. The majority of the Jewish people in the United States are Ashkenazi. So literally, I just pulled up the algorithm here. I click boxes. I enter the age, I enter the weight, I enter the height. I answer all the questions by clicking boxes and add the family number of family members and then push a button and it spits. It then spits out the risk is how that model works.
So the Tyler Krusik model, is that considered the gold standard?
It's the generally preferred model, so I would say yes.
And
And
that's
what they
outside of
calculate is the
testing.
likelihood, um, the likelihood that you will have a positive BRCA test. That's what it's not predicting the risk of breast cancer so much as the likelihood of that you carry a BRCA mutations.
I'm curious what, if you would put in that patient you were talking about, I wonder what her results would have been.
Oh, they would have been through the roof.
That's so interesting. Why does insurance still require family history before approving genetic testing? When there's so many women being diagnosed with breast cancer and younger. Last time we spoke, you talked about insurers being penny wise and pound foolish, which is spot on because they don't pay for the genetic counseling without a family history. Or if there's they only pay if there's a breast cancer diagnosis. So do you have any sense that that will change?
I don't think so. And I'll tell you why, because these algorithms are pretty accurate. And if people have, I mean, you have people who come out with risks of carrying the gene less than 1%. Now, it may change a little bit in terms of what groups are tested, but if your risk is less than 1%, so every 100 people that you're testing, 99 will be negative. That's spending a lot of healthcare dollars to do testing, which is negative. And when we think about something such as mass screening and mass testing, we need to think about what the yield on it is, because every dollar we spend in healthcare on one thing means we can't spend it to another on another. So, for instance, I'll give you an analogous example. If a woman has breast cancer, should they have a bone scan before they have surgery to make sure they don't have bone metastases? If their lymph nodes are negative, the answer is no. And the reason is less than 1% of people will have bone metastases. And of those who have a positive scan, the majority of them will be false positives, where you found something suspicious. It turns out to be nothing, but in the meantime, you've caused all sort of anxiety and discomfort in patients. So you want to direct your testing to the people where you're likely to get positives, because there are false positives and you're more likely to create harm than good. So I think blanket testing for this particular gene, these mutations, is using our current technology is probably not appropriate, frankly. Now, will we eventually have screening tests and blood tests that screen for multiple different cancers at once, available at low cost? I think we will. So I think that day may come, and this may change a little bit. But right now, we're realizing that everything we do in healthcare, every dollar you spend is a dollar you're not going to spend someplace else, especially with plans such as Medicaid, which I work with all the time. We have limited pools of dollars, and
Right.
why are some things covered and not covered? You want to direct those dollars where they will get the greatest benefit for the greatest number of people. We'd love to have unlimited funding, but we don't. And if you spend money on tests that have almost zero probability of helping you manage the patient, that may be some maternal health care or child health care someplace else is not covered. So it's the difference between looking at the population and looking at the individual. If I was saying an individual, sure, screen everybody. although I still worry about false positives. But when I look at the reality that we need to take care of everybody for every condition, how do we spend our dollars most wisely? So it's a good question, and it's a difficult question, but in my mind is the reality in the world we live in.
Well, vis-a-vis the expense of treating someone for cancer, which is, stupendously expensive, I would think that it would make sense to go the less expensive route. I mean, I understand that genetic testing is expensive in its own bracket, but putting that next to caring for someone who has cancer, it's a smaller amount.
Not really. That's the thing. When you look at the cost of the testing over 100 people, say it's $3,000 a test, you spent $300,000, and it's rare to spend that much taking care of a breast cancer. So you want to instead find the people, not waste that money testing the 80% of people who have next to, or 80 to 90% who have virtually no chance of having the mutation, because we're very confident about these algorithms, and they're even going to get better with artificial intelligence. There's a lot of work being done where artificial intelligence looks at multiple factors and gets even more accurate. So you can spend a lot of money testing a whole population with the percentage of the population will be small. So it's not cost efficient in this case. There are cases where you're right, where it's penny wise and pound foolish. But in this case, to spend that money on an entire population, you would spend more than you would taking care of the breast cancer cases you miss. Not to mention, if you already are going to screen the people who have the high likelihood on the algorithms, the remaining population, you're going to have on the order of one, as I said, 1 out of 100. So it's hard to justify it on an economic basis. And as I said, false positives are a real problem, because then you put people through multiple tests and biopsies and things that aren't going to help them and may hurt them. So that's why there was a reluctance. I mean, you could take the same argument and say, why not start screening for breast cancer in all women at age 20? You could.
Oh, yes,
and we
that
could
would
do
be.
MRIs and ultrasounds, but you'd find very few cases of breast cancer, and you'd spend a ton of money doing all those MRIs and mammograms. So we don't want to admit it, but it's an economic decision about getting the healthcare dollars to the people at greatest need. And none of us like to talk about that in healthcare. We don't like to talk about the fact that economics plays a role in the algorithms and into the decisions. But that is what it comes down to, as well as, again, we don't want to generate too many false positive tests. Because they can be harmful to patients.
Now, so would you say that the Tyler Krusek model, the algorithm, would you say that's the future vis-a-vis?
I think that's the best we have right now. I think artificial intelligence is going to surpass it.
What is the most important thing for patients to understand about prophylactic breast surgery? Or maybe patients and providers?
Yeah. One most important thing, I would actually want to say two. Most important thing, it is the most effective way to prevent yourself from ever getting breast cancer. And then number two would be but though highly effective, it is not 100% effective. There is still a very, very small risk of developing breast cancer. Though I will add a third point. I'm sorry, but the third point is it's very easy to diagnose breast cancer in who's had bilateral, well, if they've had reconstruction, it gets difficult, but if they haven't, you see it on the chest wall right away. So it's very obvious, though it's not quite as simple if you've had reconstruction.
Dr. Andrew Hertler, thanks again for an essential and informative talk.
Well, thank you very much. As
You're the
always,
best,
enjoyed
Dr.
speaking
Hertler.
with you.